This has been really great discussion about, I think, some very important topics, challenges, opportunities. Again, I think it's nice to hear, I think we were talking earlier about, boy, it's nice to know that everybody has the same questions and that it's ubiquitous no matter whether you're in medical oncology, urology, community, academic centers. So we're going to shift gears a little bit and, again, talk about another great new therapeutic option, which is Radium-223 and its use in terms of management in metastatic castration-resistant prostate cancer. So, Mike, give us a little overview on Radium-223, what it is, mechanistically how it works, how you guys are utilizing it in a big urology practice.
So Radium-223 is an alpha particle. It was a compound actually initially developed in Northern Europe. The compound seeks out rapid turnover in areas of the bone with rapid turnover, the osteoblastic met that you would see in prostate cancer, for example. It's infused. The compound's actually 1 cc of medication, and it's infused and has actually been shown in the Alcimca trial to improve overall survival, 14.9 months versus 11.6 months. It also has been shown to be very safe compound. Those were the two primary endpoints in that trial. Very little myelosuppression, very few side effects. In fact, in that trial, about 60% of patients had received previous chemotherapy, so they're already fairly down the path of advanced prostate cancer, and these patients tolerated the drug very well. It actually looks like it decreases skeletal-related events as well, with many of the other compounds we've talked about in this setting.
So, Judd, you and I are old enough to have used radiopharmaceuticals in the past, right? So how does, for the audience that may not be as well versed, well, we've used this in the past, and these are tough drugs. How do you differentiate? Why is Radium-223 different from the samariums and the strontiums?
So you're right, we grew up, we had samarium and strontium, and one I remember trade name was Quadramet, and the problem with those agents is if as a urologist, I remember if we pulled the trigger for one of those agents back in the day, our medical oncology partners would not necessarily be happy with us because of the risk for myelosuppression, and the concern in that era was, one, no real documented survival benefit, and two, the myelosuppression may limit the use of chemotherapy. So they were always a challenge, although they were useful for bone pain. Now with Radium-223, which is the first radiopharmaceutical that actually has a documented survival benefit, and the risk of myelosuppression is much less. It's not zero, there is still some risk, but it's much less. So the drug can be administered a little bit easier and can be done a little bit earlier and doesn't burn the bridge for chemotherapy.
So Mike, as Mike mentioned, so Alcimca was the registry trial. It was a multinational trial. I believe you had to be minimally symptomatic or asymptomatic. You could not have had planned cytotoxic chemotherapy to be given concomitantly. However, there were a number of patients, what was the number, Jorge, that had actually received cryochemotherapy in Alcimca?
Yeah, so what Mike said, around 60% of patients have.
And you could not have visceral mets
correct.
as well.
No visceral mets. So getting back to now this discussion, because again, we have all these therapeutics. So from a medical oncology standpoint, we know there is, like Mike said, there is still some element. You still could have some element of myelosuppression. How does that change your thinking in terms of layering, sequencing, the terminology, however we use it, with potential use of concomitantly with taxanes, et cetera?
Yeah, I think that one of the challenges that Radium-223 has faced in North America is the lack of understanding between what an alpha particle is and what a beta emitter is, right? And I think that is still a misconception that, it's another radionucleotide that will likely lead to the same myelosuppression without survival benefit, which is not the case. The second issue is that the patient population of Alzheimer's was a very heterogeneous patient population because some people have chemotherapy before, some people were chemotherapy naive, right? Now, it is important to remind you that when you look at the Alzheimer's data, patients with visceral disease were not allowed to be enrolled in the trial, but more important than that, is how much pain you needed to have to be enrolled. And in that data, actually around 40% of patients or so were not taking opioids, suggesting that you don't need to be taking opioids to actually benefit from this therapy. The second challenge that I see with Radium-223 is how do you think of it? When do you use it? I fundamentally believe that Radium-223 is not either or, right? In my personal practice, I think that Radium-223 should be utilized as a continuum of the castration-resistant process. And that means that when I make that decision that a patient gets on Radium-223, I don't necessarily have to stop my oral therapy, right? In fact, if you look at the best supportive care as how it was defined in the Alzheimer's data, they allow ketoconazole. Well, I don't think of AbbVie as a ketoconazole, but I think it's a much more selective, powerful agent, more expensive, but yet leading to to similar mechanistically speaking, similar efficacy. And when they allow also AR blockers, and obviously they probably were referring to nilutamide, flutamide, bicalutamide, but enzalutamide is an AR blocker. So for me, philosophically, I think that and most of my patients, when I start therapy early, they actually stay on oral therapy, and I piggyback and I add a Radium-223 into that context.
We do the same thing. And actually 4% were on enzalutamide. Correct. It just hadn't been approved.
Correct.
To that point. 20% were on abiraterone in this trial. So you can continue these medications.
The chemotherapy combination is a little more complicated.
Correct.
But certainly I think that's the direction things are going. I actually, when I first saw these data a few years ago, of course we had phase 2 data, which looked impressive, and the phase 3 data were very similar. I wondered if this would be a therapy that would basically replace zoledronic acid and denosumab, and I think that's the other sort of avenue to talk about, which is that I don't think that it replaces denosumab. In fact, if you look at the data from the expanded access program, the patients who took both radium and rank ligand inhibitor had a superior outcome.
Yep.
Yeah.
So it's not one or the other, it's sort of additive.
And I think it's important to make note that these patients can be on a baby aspirin or a Tylenol for pain. They may be taking this, and a lot of it's not oftentimes reflected in the medical record medication list. So you really have to talk to these patients because they may take the Tylenol every day but fail to tell the nurse inputting the data that they're on this medication regularly. They just take it for symptoms. And these are the patients you want to use this on, as we were talking about earlier, the continuum or a little earlier. Yeah. Patients with metastatic disease or castrate resistant benefit from these drugs, particularly Radium-223.